So at the outset, I am thankful to organizing team for inviting me to deliberate in this symposium. And Prasun has already given a background at how we should evaluate for the patients with osteoporosis. I'll just say that the osteoporosis is an outcome of increased longevity. You are living longer, so you are having a more osteoporosis and fractures. If you recall, say 25 years earlier or 20 years earlier, whosoever used to have a hip fracture, they used to be bedridden, and even the modus operandi for the demise was this hip fracture. So patient earlier used to die with a hip fracture mainly because they were bedridden and eventually having a sepsis and they died. So now we have got so many modalities to treat osteoporosis and which we can overcome. And in fact, the plethora of anti-osteoporotic medications have made it really difficult to choose that what we should choose for that, one, and secondly, how to choose, whether sequentially, whether combined. So that is now a difficult question posed by this. So I will try to, however, it is a slightly difficult topic, but I will say that because a lot of new data has come, so I will make it a very simpler talk for you, and I hope I will be able to communicate with you people. So this has already been covered, but only thing here I will tell you, the addition and a definition is a microarchitectural deterioration, because even with the teriparatide for hip bone, you have got a decline in BMD, but still you have got an improvement in microarchitectural deterioration is prevented. That's why the fracture is less with teriparatide, despite lesser decrease in BMD in the hip as compared to spine. I will leave this, I will just come to goal. So what is the goal of these therapies? So to prevent the occurrence of fracture. I think it's a very simple, but you see that by making it this simple statement, there are many fallacies. The fallacies are, it is difficult to judge when a fracture has been prevented by the treatment which you have administered. We don't know that this fracture has been prevented really by the treatment which has been given. Secondly, we don't have a threshold for a BMD which can really reduce or prevent the fracture. Like for a diabetes, you have got a hemoglobin A1C below 7%, and you say that the hemoglobin A1C below 7% is associated with no diabetic complications. Similarly, we don't have a threshold for BMD that is good enough to say that this threshold is certainly going to prevent fracture. Thirdly, the effect size of a BMD on fracture risk is not known, because the BMD is not the exclusive determinant of the fracture. Other than that, you require a good muscle mass, you require a good muscle strength, and you should not have a parental history of fracture. All these factors, and you should have a good vision. Even if you fall, you will have a fracture despite having a normal BMD. And lastly, most of the data which are available, they are for increase in BMD rather than incident in fracture. So available therapies, anabolic and anti-resorptive. You have a plethora of medications, and this is the phenomena which I want to show that. This is a basic multicellular unit. This MCU has got 4 cells which are involved: osteoblast, clast, osteocytes, and lining cells. All these cells are very well functioning in a very synchronized, disciplined, and a very ordered way to cause the bone remodeling, to provide the bone strength and quality. Various hormones, growth factors, are playing a role in modulating the activity of this. The whole cycle of bone remodeling, that is activation, resorption, and formation, takes around 90 to 120 days. The process of resorption and formation goes on hand in hand. But how to intervene? When to give really PTH? When to give really bisphosphonates or a denosumab? That is the question for which we are really struggling. That's why a lot of data which I will show you is that the sequential therapy, combined therapy, that's why we are not still able to find what should be the sequence of events in the management of osteoporosis. This is about a PTH analogs. We are using 1 to 34. However, previously 1 to 84 was available, but this has got a more bioavailability which has got now available. Its half-life is around 75 minutes and the dose is 20 microgram. The most important question which we have understood after this availability of the teriparatide, it should not be used beyond 2 years. This is called anabolic window. I'll just try to illustrate you what is the concept of this anabolic window. PTH is a double-edged sword. If you give PTH in excess, or if you give a PTH like in a endogenous PTH like a primary hyperparathyroidism, you have got a bone resorption and fractures. But if the same PTH is given intermittently in a low doses, it causes a formation of bone. Why this happens? So the dose of a PTH and the frequency of administration of PTH is very critical. If you use in a higher doses, you will have a fracture. If you use in a lower doses, it will reduce the fracture. I think this critical question has been explained by the anabolic window. So what I mean by that, how long you can lead to formation of a bone by giving a PTH. So if the PTH is given in a small doses intermittently, then you have a more formation of a bone formation markers. And these bone formation markers, there is a steep rise and continues to rise and reaches a plateau at least for a period of 12 months. And after the 12 months, then there is a small rise in bone resorption markers, which eventually reaches by the 24 months at a plateau. So meaning by that, bone formation and bone resorption markers, they reaches at plateau by 24 months. So meaning by that, continuing teriparatide beyond 24 months may not be useful because the formation and resorption markers are at a plateau. And in fact, they start declining after that. Another point which I would like to share is that the initial part of the bone formation, when the bone formation markers are more, then the PTH leads to modeling. Modeling means the laid down of a new bone over the quiescent bone where it has not been resorbed. So this is an exclusive action of a PTH on bone formation related directly to the bone formation markers. But when the bone resorption markers, like in this slide you see at 12 months it start rising, then you have the modeling and remodeling both starts. Remodeling means laying down of a new bone over the resorbed bone. That is called as remodeling. So you should understand modeling and remodeling are the two terms. Modeling, even in a normal physiology, we have up to the peak bone mass around 25 years of age. After that we have a remodeling, means resorption followed by formation. So this anabolic window is a very crucial and important in deciding the duration of the therapy of PTH. Now question here arises that can we increase this duration of anabolic window? Yes. So like you can see that at 12 months when the resorption marker are increasing, you can give an anti-resorptive agent at that time and you can prolong this window for this so you can have more bone mineral density. So I think people are trying to look into those that how can we prolong this period of an anabolic window so we can have a maximal achievement of a BMD and consequently this will translate into reduction in fracture. So another agent which is abaloparatide, that is a PTHRP analog, and it has got a less catabolic action, reduced calcium mobilization, and it's a binding with the G protein coupled receptor. So it binds to the RG conformation of a G protein. That's why it is more potent and less calcium mobilizing. So now we say that the treatment strategies which are currently available is a fall prevention, optimal supplementation. So we will show the data of anti-resorptive because which we are using in clinical practice for a long time, anabolic, sequential and combination. So long-term bisphosphonate therapy have got a good data available. So we have got both the drugs alendronate and zoledronic acid. If you see that the data for a first 5 years of alendronate, there is at most 50% reduction in fracture rate. Similarly with the zoledronic acid, you have got almost 50% reduction in fracture rate. But question is asked that how long you have to continue the anti-osteoporotic therapy. So people have done the studies which are showing that if you use for alendronate 5 to 10 years, but in fact you do not reap any benefit in further preventing the osteoporotic fracture. So meaning by that the maximum duration of a therapy till the alendronate is useful and till you are having a really benefit in a fracture rate is around 5 years. As far as zoledronic acid is concerned, even you give an extension for a 4 to 6 years, there is some reduction. Drug to drug means zoledronic acid continued for 6 years. So even we can say for a zoledronic acid up to 6 years it is fine. But if you continue alendronate like for a period of 10 years in an extension flax study, you didn't reap any benefit because the relative risk reduction is only 14%, which is not significant. So what we can conclude is a long-term bisphosphonate therapy, like zoledronic acid for 6 years and alendronate for 5 years is good enough. Whatever the maximum benefit you accrual in a BMD is achieved. After continuation of this, you do not reap any benefit. But as I told you that osteoporosis is a progressive disease. It's a disease of increasing longevity. So you will require some modalities of therapies, which we'll discuss. Then the concept of drug holiday came because if you give an bisphosphonates for a long time, you have got two uncommon complications, but they are of major concern. One is fractures. If you continue long-term bisphosphonate therapy, you have an atypical fracture, and this is called as SSBT, that is a slow suppression of bone turnover, severe suppression of bone turnover. So you usually have a fracture of the shaft of the femur, which is not an osteoporotic fracture. So here what is happening is that your cortical bone density is more, but the bone in fact is weak because your remodeling is inhibited by long-term bisphosphonate therapy. And another problem which you have with a long-term bisphosphonate is the osteonecrosis of the jaw. These are two uncommon complications, but you prolong the therapy beyond 5 years, you are likely to have this. That's why a concept of drug holiday came. So give a drug holiday for 2 years, look for a bone turnover marker. If they again start rising, you can reintroduce, or you can have other options. But the drug holiday has to be taken into consideration if you have issues like this. Then you have a 10-year denosumab is a drug which is an antibody which is inhibiting the binding of a rank ligand with a rank, and you have what 10 years data of a denosumab which is very clearly showing the new vertebral fractures and hip fractures are prevented. The first line anabolic therapy where you like to use teriparatide to begin with the pre-existing osteoporosis related fractures, BMD T score even less than 3 even without fracture, and sometimes you are finding a suboptimal response to bisphosphonates. You can also appreciate there is a difference in a bone remodeling with a teriparatide versus alendronate. Here you find really that the trabecular bone is much more higher BMD with a teriparatide than alendronate, and the reason for that, if you have a look on a hip bone, then the major effect of alendronate is on a cortical bone, while the teriparatide does not have a much more effect on cortical bone, means hip bone. So meaning by that, those patients who are predisposed for a hip fracture, the choice of therapy should be more towards a bisphosphonate or a denosumab, while those who are more prone for a vertebral fracture, the choice of therapy should be more teriparatide. The next question comes, if you give teriparatide for a period of 2 years and you suddenly discontinue, what happens to your BMD? It quickly goes down. And you can see that because a lot of the osteoclastic units which have been activated by that, and you can see that as you discontinue therapy, there is the same pre-treatment or almost pre-treatment level you achieve. So to overcome this, people have devised the sequential therapies where anabolic followed by anti-resorptive. So this is one of the example where the patient has received teriparatide, followed by they have been given alendronate. If you focus only on a red mark, that very clearly shows that those who received, I think if I can use this point, yes, those who received teriparatide followed by placebo, they did the worst, while those who received teriparatide followed by alendronate, they did the best. So meaning by that, teriparatide whenever you use, it has to be followed by an anti-resorptive therapy, preferably either bisphosphonate or denosumab. Similarly, again showing that if PTH, if there is no medication is given, so if you abruptly discontinue after 2 years of teriparatide, you are likely to reach the same pre-treatment baseline values what you had earlier. Now, what about the denosumab? If you have a teriparatide to denosumab, then you can see that by adding denosumab is more potent than bisphosphonates, and you can appreciate the percentage change after putting on denosumab was around 8.6, means 9% almost additional gain in bone mineral density, same in femoral neck and total hip. So meaning by that, when you use teriparatide and when you plan to discontinue, addition of either bisphosphonates or if your patient can afford denosumab is a better choice. This is to show that how the patients who have been treated with teriparatide followed by denosumab did reasonably well at the end of the study of 4 years as far as lumbar spine was concerned. And if you look for a hip, then you are again having a reasonably good. Yes, those who received combined, I will discuss that, they did slightly better. But remember here, last point, the red point, those who received denosumab first followed by teriparatide, they have got a decline in spine BMD as well as in hip BMD. So the question comes, because the denosumab you can give up to 10 years as the data is available, but when you withdraw denosumab, what you should use, I think that you must use either bisphosphonates or that must be used to prevent the post-denosumab decline in bone mineral density. This is the data with a PTH-RP analog, and if you can see that, those who received alendronate and those who received abelo followed by alendronate, they have got 84% risk reduction. So meaning by that, any anabolic therapy is to be followed by anti-resorptive therapy. This is about the romosozumab, which is an this antibody to sclerostin, and this again showed the romosozumab is better than teriparatide. So it is more potent than teriparatide. However, initially there were some cardiovascular events with that. That's why there was some hesitation. But again, they have reanalyzed the data and shows that the romosozumab is doing better than teriparatide. As far as the sequential therapy, the anti-resorptive followed by anabolic therapy. So whenever someone has received a bisphosphonate, like in our clinical setting, majority of patients have received bisphosphonate, and if we give a teriparatide, effect is always lesser. And the reason for that, you have a reduced active bone surface, and you have already increased endogenous PTH levels because of secondary hyperparathyroidism after bisphosphonates. That's why the therapy with the teriparatide following bisphosphonate is less effective, particularly for a hip BMD is concerned. There may be again two strategies, and what people have shown that if you give, so this is a patient who has received teriparatide initially, then those who received alendronate as an add-on, they did better for lumbar spine as well as for hip, while those who received only alendronate, they didn't do well. So meaning by that, those who received earlier alendronate, they should have an add-on with the teriparatide that is better rather than only having a teriparatide. This is with the romosozumab. Again, you have a better data with the romosozumab than teriparatide. Another group which I talk, when you talk about denosumab to teriparatide, then again you don't have a much beneficial effects if you prior give a denosumab followed by a teriparatide. Now last area where the people have talked about, they have used as a combination therapy, where they use a combination of a zoledronic acid and teriparatide, zoledronic acid and teriparatide alone, and you can see that the zoledronic acid and combination, they are doing the same. So that's why the combination therapy is not recommended. However, there is a data with a denosumab with teriparatide as a combination therapy, they did better. The reason for why the denosumab and teriparatide did better than zoledronic acid and teriparatide, and the reason for that, because the effect of a denosumab is only lasting for a period of 6 months, so it allows the PTH to exert its modeling effect. So the combination which is really going to be found to be effective is when you are using denosumab and teriparatide together. So yes, a word about osteopenia, the last study which we had in NECM, and that showed that even zoledronic acid at a frequency of 1.5 years can be used even in patients with osteopenia. So to summarize, the treatment-naive osteoporotic patients, they are best benefited with anabolic followed by anti-resorptive therapy. Patients who have received earlier anti-resorptive therapy, they respond better to a combination of teriparatide and bisphosphonate than teriparatide alone as far as BMD is concerned at all sites. Teriparatide following anti-resorptive therapy may lead to decline in BMD at hip. Therefore, those who are at a risk for developing hip fracture, they should be add on with bisphosphonates. Bone turnover marker is not useful in prognosticating the fracture, but they should be useful in guiding the therapies. Say for example, the bone turn markers are suppressed, they discontinue bisphosphonate. And one more point I would like to add, whenever you discontinue denosumab, you always follow it by bisphosphonates. And osteopenic patients can also be benefited with bisphosphonate therapy with appropriate drug holiday. Thank you. Thank you for your patience hearing. If there is any question or comments, I will be happy to answer.